Your Excellencies, ladies and gentlemen, I am delighted to see you here. It just shows that quality, not quantity, is what we want in an audience. And we're sure that people will join us along the way, but we're really delighted to have those of you here that are with us. WISH is about making connections and sharing ideas and coming up with new ones. So just before we start, could you just stand up and turn around to someone you don't know, shout at them and say why you're at WISH, what you hope to get out of it, and what's your relationship to eye surgery and eye care. Just very quickly, let's just get a quick conversation going. Just introduce yourself to someone you don't know. Great. Great. Come then. Because I see lots of people sitting together, but some people sitting alone, maybe out of choice. But I think it's quite good just to have a quick chat. Then you'll be happier to speak, I think. Okay, now you can swap holiday stories later, that's fine. Thank you very much indeed. Now let me introduce our panel. Professor Govind Naidu is Associate Professor of Optometry, University of KwaZulu-Natal. He's the founder and the former Global Director of Our Children's Vision Campaign, a global campaign to screen 50 million children by 2020. Then we have our next guest, and that is Liz Smith, the co-founder and chief executive of Eye Alliance. She spent the past 11 years working in international development, focusing on inclusive business and global markets, and her aim is to close the gap in access to eye care and eyeglasses at a global scale. Dr. Adaya Al-Harimi is a consultant ophthalmologist who has worked in ophthalmology department at Hamad Medical Corporation, Doha, for more than a decade. Dr. Adaya specialized in cornea and refractive surgery. She's also the Associate Program Director for Ophthalmology Residency Training Program under HMC Medical Education. Dr. Hannah Fowle is the past president of the International Agency for the Prevention of Blindness. After a long and distinguished career, including working with WHO International Center for Eye Health, she's busier than ever in supposed retirement, including membership of the Global Advisory Board of Our Children's Vision and chair of the board of the Africa Research Vision Institute. Ms. Angelia Sanders is the Associate Director of the Trachoma Control Project for the Carter Center in Southern Sudan, Uganda, and Ethiopia. Next year, she's taking over the Vice Chair role for the International Coalition for Trachoma Control, working to support the WHO Alliance for the Global Elimination of Trachoma by 2020. And last but certainly not least, Serpeng Kaur, the Forum Chair, who led the report, and we're going to concentrate on that today. Serpeng is Program Chair for the Eyes and Vision Program at UCL Partners, the Director, NIHR Biomedical Research Center, Moorfields Eye Hospital, and UCL Institute of Ophthalmology. I've done this a bit so many times in front of the mirror. London Ophthalmology, and has a long track record of developing new treatments from laboratory thought to international clinical trials. Peng is going to speak to the report first and its recommendations, and then we're going to have a panel discussion and as much involvement as possible from you, the audience. So, Sir Peng, first of all.
Well, thank you very much, Kirsty. That's very kind of you. And thank you all for coming. This is obviously very important to have eye health represented here at this very important meeting. And it's very good that you're all here. And also, I thank the panel. I'd really like to, first of all, acknowledge Mark Steedman, who's here in the audience, from Deloitte, and Karen Taylor and Natalia, and also the rest of the forum panelists from all over the world who contributed so much to this report that you will have available and you can get at the Innovation Center. So just very briefly, now how do I move on? Yes. One of the things that we wanted to establish out of this one is really to reiterate the importance of eye health to people. And, you know, just like, we know that everyone in this room, if we all live a normal lifespan, will be affected by some form of eye pathology. And so it's very important that, and it's reflected in this YouGov survey done for WISH, which really shows that in all the continents here that were surveyed, it's a nice opportunity. More than 74% of respondents answered sight, of course. And if you get rid of the don't knows, it's even higher than that. So there's no question that it's our most precious sense. If you look again at this map, and again we've got representation here on the panel, and I certainly in the audience, of the prevalence of visual impairment, and looking around you can see that certainly certain parts of the world carry a much larger burden of visual impairment in the world, and this is essentially an enormous problem. If you look over here at the causes of worldwide impairment, there's a wide variety of conditions causing problems, and you can see it's not entirely proportional to what you see in that map, because you see that cataract and uncorrected refractive error account for a large amount of visual impairment worldwide. But hidden amongst these graphs is a lot of other trends, and we'll just have a look at that later. But for instance, in uncorrected refractive error, the incidence of myopia is rising throughout the world. And if it continues to rise at current trends, it will start hitting sort of epidemic proportions. And of course, high myopia is associated with a lot of other ocular pathology. So hidden in that refractive error also lies that issue. On the right-hand side of the graph, age-related disease, which is macular degeneration, cataract, diabetic retinopathy, which is also lifestyle-related, and glaucoma are all on the march. And they're all increasing, again, because of the aging populations. And this will become an enormous problem as we move on. And that's again reflected in this slide. Because in the last 25 years, the prevalence, although you see a steady increase there, the prevalence of eye and visual impairment has stayed roughly steady because of very dynamic programs by some of the people you've seen here and organizations around the world. But if you look at that little bit of the graph that's in gray, you can see that actually this is going to change dramatically. And even the transition, you've heard a lot at this meeting about communicable disease, non-communicable disease. Even in the parts of the world where communicable disease is important, such as trachoma, we're going to see a change. And these will move into the diseases of aging. And if you assume there that the resources for healthcare are staying relatively steady or increasing slightly, you can see the scale of the problem that we face worldwide. And given that, as I said, every single one of us, if we live a normal lifespan, which I'm assuming is the case, will suffer from one of these conditions, you can see the scale of the problem that we're about to encounter. So if we go into the policy recommendations, now obviously there's much more detail in the report. And again, we're going to discuss this in detail, but in this report here, you'll see very much more detail about these points. But I'm going to keep these very simple because we're going to discuss that. The reason why prioritization is very important here is that although vision is our most precious sense, and actually the economic consequences of losing our vision in terms of social and economic are so high, and the return on investment of investing in eye services is so high for many thousand% in many cases, this message doesn't really reach stakeholders and policymakers. So this is a very, very important message that must be taken forward into the future if this is to become an integral part of healthcare that we deliver. We need to really look at ways of achieving sustainable universal eye health, because really that needs to be an integrated part of general health for for people, because the consequences for quality of life and economic costs of healthcare, of vision loss are so high that this is a critical feature. The issue about the power of partnership and collaboration is very, very important, Because again, it's the partnership between the NGOs, between government, and actually industry as well. Most of the innovations in healthcare have arisen often because of research in industry. So again, that has to be part of the collaboration as we move forward, and of course, collaborations with our patients and partnerships as well. The issue of education and training also becomes critical, and you'll see many organizations here. There's Aravind, there's Elvi Prasad, the Orbis organization, which you've heard about, also is a great emphasis on their training. And also the issue in the future we must consider is who's going to do parts of the healthcare pathway. Traditionally, the very heavily medical-based model probably has to change. And again, in the report, you'll see examples of how that might change. For instance, in the recent Biobank study, which is the largest study of its kind in the world, all our eye examination protocols were done by people we recruited from the supermarket checkout agency. And they were done actually at a quality level which was probably better than we achieve in most hospitals because of the technology associated with how we did the survey on 120,000 people. And we did it in 10 minutes. So again, we have to begin to think who does quite a lot of the different parts of the healthcare pathway. And finally, the issue of technology and innovation. You've seen the demand curves that we are facing. If we are not going to use technology, we are going to find it an innovation, which is one of the themes of the WISH meeting. We are going to struggle to meet the enormous demands. In many countries of the world, including countries, for instance, like the UK, which probably has, one of the highest healthcare resources in the world, not the highest, of course, we struggle. We're struggling to meet the demand for the increase in macular degeneration and glaucoma. Now that's in a very highly prioritized, a highly resourced situation. So you can imagine how hard this is going to be right across the world as the transition occurs into the diseases of age. So innovations such as, for instance, we've been working in artificial intelligence recently. We have an algorithm now working with DeepMind, which is now owned by Google, which is probably as good as any of our consultants in diagnosing most of the major diseases of the retina, and is equally good as our best consultants in prioritizing which ones are urgent and which are not. Other innovations, such as new surgical techniques, which could treat a disease in a much more rapid time and have much less in the way of patient visits, may be another way of addressing these chronic diseases, just like we have with cataract. So at this point now, I'm going to stop, and we're going to turn to the most important part of the day, which is the discussion between you, yourselves, and the panel, led by Kirsty, to discuss these incredibly important issues, which will become one of the major challenges for healthcare in the next few decades. Thank you.
Thank you very much indeed, Peng. Do come and sit down. Before I go on to the rest of the panel, do take the microphone, and I just want to sort of, there's absolutely so many fantastic things in this report, not least the case studies and things that are quite mind-boggling. Just to drill into that again, what I thought was fascinating when you said that one of the series of different studies that were done was done in 10 minutes by supermarket checkout people because they understood the technology. That has huge potential.
Yes. Well, that was an interesting issue because, and of course, it's because you're challenged. What happened was when the Biobank said was doing this series, which is blood and a huge series of different examinations, and when towards the end of the series, they then wanted to think about doing things like MRI imaging of the brain and the eyes, and they rang me up and asked me if we were interested in doing eye examinations. And you can imagine what I said, let me at it. And basically they said, come and pitch to the committee, but I have to warn you about one thing. You're going to have to raise £500,000 per minute for everything you want to do with the patient. So that makes you think a little bit, $500,000, because normally in the NHS, to do this series of tests takes about maybe 1.5 hours. Now, I'm no accountant, but that's a lot of money. So we convinced them about the case, not just for eyes, but for the body, what the eye could tell about the body. And so we went about using every technology possible to speed up the examination. That included things like, we noticed it took about 3 minutes to fill the patient's name into the machine, so we used things called RFID chips, which they touch, it takes about a second. Even to the detail of noticing that we were wasting time moving the machines up and down, so in the end the patient went up and down, and so we reduced it to 10 minutes. Because we were, again, having to reduce costs, we had very, very good standard operating procedures linked to the technology so that actually we recruited from the supermarket checkout.
But how did you know to do that?
We didn't. We had to. So basically what we did was, because the costs were restricted, we discovered, because they were using similar people for some of the other medical tests. So with very good protocols and very good control, because everything was monitored electronically, all the machines were connected.
Right.
And the control center was in Cardiff, which is in Wales, and all the centers were across England. And basically, if an operator, number 6 in Brighton, the readings were going off because they were wrong, the Cardiff Control Center would pick that up within 5 minutes and ring them and says, the operator's falling asleep in number 6. Right? This is the degree of control of quality that
and she's just sold 6 oranges instead of doing an eye test.
Right. Okay. So, of course, the implications of this for not just eye care, but all care is very, very pertinent, isn't it? Because if we're going to cope with that number of people, we're going to have to think of new ways of carrying out tests, because generally chronic disease requires people to come in, have a series of tests, not even necessarily in hospital, and then be reviewed by somebody and then decisions being made. Of course, many parts of that pathway can now be replaced by very, very efficient bits of technology.
So, another thing in the report, Kovan, was the idea that we are actually going on to have much more issues with myopia. And I wonder, as the former global director of our Children's Vision Campaign, some of the biggest barriers to improving eye health for children and adolescents, and is it actually going to get worse because of some behaviors?
It is. Let me set the context by saying that in a lot of the studies, if you were lucky, you had at least 20% of those who needed correction having correction or getting access to eye exams. And in some situations, when you look at spectacle provision, it has been as low as 0% in some of those more rural communities, etc. So we do have a big problem. The WHO says there are 19 million children in the world who are blind or vision impaired. That number is really old. There hasn't been an updated study in a while, so it's even higher than that. So we've got a big challenge. But again, you know, if you look at the results and you read the report, you'll notice that we've made progress. Yeah. Prevalence is falling. So I refer to myopia as the spoiler alert, because myopia is going to change the game. It's going to push the prevalence back up, especially for vision impairment, because we know by 2050, half of the world's population will be short-sighted. And the WHO myopia report has accepted that number, etc. It's the number that we are planning towards, and we're heading for a major public health crisis. But what's more worrying is that 20% of those people will have high myopia, which means they could have permanent vision impairment and blindness as adults mainly, some as kids, but as adults. But that's going to put enormous cost on the system.
But if that's a figure that's accepted, is it something they know that can't be reversed, the increase in myopia? Why are they so sure that it can't be reversed?
So we know why the trend is occurring. Well, we almost know, because initially we thought it's because they're doing near work. Now we're starting to understand it's actually because the kids are not spending enough time outdoors. So, but whatever side of the equation you are, the reality is that there's lifestyle changes occurring. And if you look in Africa, for example, in parts of Africa, people have missed the phone, the regular phone, they've gone straight to mobile technology. So even in poor countries, the spending more time on devices and spending more time indoors is going to be a huge issue. So, and then you are faced with the fact that there's lack of services in most of the developing world. And when you talk about children, the big challenge we face is that you need to train pediatric ophthalmologists who are specialists within specialists, right? Ophthalmologists, there's subspecialty within ophthalmology. And, you know, it's not uncommon, and Orbis does a lot of work in this, and they can give you the stats. In some countries, there's no, or some provinces, there's not a single pediatric ophthalmologist.
But you have to have an ophthalmologist to do some of the work. For example, another brilliant thing in the report was the Peak app. You can actually start to develop that you don't actually have to have that level of expertise to diagnose and treat. Well, treat's the other issue.
No, absolutely. I think there's been an increasing trend to address the barriers of screening in school children by teaching teachers how to do that. And what we're finding is that studies are showing that there's a lack of confidence, so that results vary. They're good in some cases and not. But we're also finding out that the reason a lot of parents don't take their children for eye exams or don't take them to get spectacles is because they're not even informed that their children got a problem after screening. So the Peak screening, beside being effective as a quick intervention, there's an opportunity to link it up with mobile technology, and it goes back to our last point on technology, and send the patient an SMS and say, your child needs an eye exam because they can't see. And they're also providing simulations that give the parent a chance to understand what the poor vision of their child is. You know, so that's a big issue. But I think we're also faced with the fact that, you know, spectacles are unaffordable for most people. And I think that's a huge technological challenge. We know that there's some technology that bringing the price down. But a lot of that is actually more about logistics and systems and the fact that governments, even in Asia and Africa, charge high import duties because they consider spectacles as a luxury rather than a medical device. So those are, you know, things. But
it doesn't fit. It doesn't fit. If this survey shows that our vision is the most important of our senses, why, in a sense, is it the Cinderella service?
Well, the big barrier is that we have not been effective as the eye care community in terms of advocacy. You know, we were chatting before we got up here. We talk in countries to the National Eye Care Coordinator. Eye care became almost a vertical structure supported by NGOs in lots of countries, which was the worst thing that could possibly happen to us because we actually not fully integrated into the health system. Governments are not prioritizing eye care because I've heard from senior people in government in Africa, the NGOs sort it out. So in some ways, we have become our worst enemy as a sector in the way we've addressed these issues. And these are barriers that, unless we address in a very significant way, are not going to achieve this. But probably the biggest issue is the human resources. You know, eye exams, beside the pediatric ophthalmologists, many countries don't have optometrists. And then there's resistance to training others to do refraction. Because, you know, we're protective. And we're not coming up with alternatives. And I think professions, including optometry, has to start providing alternatives if we don't want certain other people to do it. And that is not happening. So that's a huge challenge that we're facing at the moment. And that is starting to change a bit because hopefully when the World Report comes out from the WHO, those of us who have been involved in the writing of it have been pushing that we don't talk professions, we talk competencies. And that'll cut always. It means ophthalmologists would have to give up certain things in countries when they can't meet the need. But it also means optometrists would have to do that. So we have to break the professional barriers and start looking at human resources and services based from a need perspective rather than a narrow protection.
But that's interesting. So in fact, what you're actually suggesting is a quite different model of care. And actually, it's quite interesting because one always thinks of the medical profession in the past as being kind of conservative, the small c. So do you think people are prepared to actually have a completely new structure?
No.
Don't be so positive.
But having said that, I was in Morocco recently at the World Council of Optometry meeting, and I made the same point to the executive and then to the governing board. And they've accepted that, set up a commission now to look at how they can focus on competencies and how they can recruit, integrate others who are not trained as a 4-year or 6-year optometrist, can bring them into the profession and upskill them. So I think there is an opportunity, but those of us articulating for a different view have to be present a strategy that's win-win for everyone.
Now, Liz, this is exactly your territory, because what you're trying to do is make sure that there is common access, no matter where you are in the world, for spectacles at a reasonable price. So tell me, what's the kind of work you've been doing?
Yeah, thanks. Well, at Alliance, we think one of our main goals is to unlock government funding and crowd in development finance to scale proven solutions. Yeah. So the premise is that NGOs and inclusive business have done a really good job at pioneering new solutions of eye care delivery and delivery of eyeglasses. And we think there's an opportunity to scale through the public and private sector. And we think there's a clear and distinct opportunity for governments to integrate glasses provision into national education programs, as well as national community health worker initiatives.
But would you also would you agree that in a way, by making it or handing off to the NGOs has been counterproductive in some countries?
Absolutely, absolutely. And so this is a key part of our work is to learn from the NGOs that have created these wonderful solutions and sometimes parallel systems, but then to embed those solutions into the government systems.
And do you find resistance?
I can speak on behalf of our work in Liberia, where we have 6 members that are doing just that. And I wouldn't say resistance. What we're finding is that we've already got the government of Liberia to integrate school eye health into their next education plan that's coming out in 2021. But what we're doing is partnering with them over the course of these 3.5, 4 years to work alongside them to build the capacity. So it's not so much resistance, but that more is required than just a policy on paper. So potentially the policy on paper will bring more funding and resources, but what we're doing is partnering to show them how to conduct the monitoring and evaluation and how to really collect data. How do you share data between both the Ministry of Health and Education? So we're working alongside them to do that. So I wouldn't say resistance, but it's complicated.
But I was just saying, I was wondering, because a report like this handed out to government ministers and countries, you'd think would make a difference, because as Peng's saying, it doesn't necessarily need to be an expensive business to do these tests. It just needs to be universal.
Absolutely. And I think as well, when we're talking about children's vision, in 2017, the Bill and Melinda Gates Foundation, the World Bank, and some other research institutions released the Disease Control Priorities version 3, which included vision in its school health package. And they recommended vision be a part of the school health package. And that included a detailed costing analysis. So those are the kind of things that when you show those to governments, it does change the conversation a bit.
And I remember 2 years ago here, there was this incredibly innovative way of getting people in Qatar, even though they didn't even realize they were doing it, to go and get cancer screening. I think it was in malls. I think it was, you took it out into the community. And I wonder what you've been able to do in terms of regular eye testing and encouraging people to actually understand their own eye care.
We always invite our population and for many patients educational activities, like in World Glaucoma Week, and which is held once in a year in March, and in World Sight Day also, which is held in October. Yeah. So where we educate our population about the importance of screening and how to prevent, and different presentations of many common eye diseases. And also regarding diabetic retinopathy, also we encourage them to do the screening. We open regularly. Just recently, we conducted an eye clinic under endocrine department, where all the newly diagnosed diabetes mellitus, they will go under this clinic, where they will be screened, and then they will have an easy access referral to eye clinic. Aha!
So you did it within another. You sort of slipped it in another department.
Yeah, and now also recently we are doing it with the Women's Hospital. Like we are implementing 2 clinics per week, where they screen all the pregnant ladies with diabetes mellitus, so they will have like early screening and detecting if there's any abnormalities back in the eye, so they will be referred to our clinic. for early management.
But we were talking earlier, we were talking more generally about eye health being all very linked to everything, including, you know, from obesity, diabetes, eye health, children's activity, and then this increase in myopia. And you were talking to me about your own kids, about limiting screen time being so important.
It's really very important.
And you tested your own kids. It's like, oh, God.
Because nowadays, even at school, they stop using these papers and pencils like the old days. Like now, everything with the iPads, and even their own tests, they do it in iPads. So when they come up to home, so I found it very difficult to just pull it out from their hands. So I'll try to limit the time or just let them get used to not to stay for a long time with this iPads. And I think the kids are smart. Whenever they learn how to stay away from this iPad, then they will stop nagging and asking for this iPad. But whenever you just keep breaking the rules and giving them the iPads back, then that will make it much worse.
And is that because of people like you know, understanding and as it were, campaigning? Do you think in schools, given that we've just started to give kids iPads, are teachers learning that actually they should restrict time in the classroom on an iPad?
I think they do, like, you know, because maybe they spend more time, like they giving nowadays the kids like more recess time, more spending time with the music or outdoor PE classes where they get them out for outdoor activities.
But the thing is that when you're a kid or an adolescent and you think, well, my eyes are fine, it's not a priority.
It is a priority.
Well, yeah, of course, but I mean, they don't think it's a priority. I mean, you know.
We always encourage, like for me, I even always tell my families and everybody just to minimize these kids, because you're putting your kids under a high risk of developing early myopia, and when they reach up by 18 or 20 years, they will be maybe -5 or -6, you never know. So always we try with them.
Absolutely. Just coming on to Hannah, I mean, you must have seen a massive change in the time that you worked in eye care, and do you fear more now than you did then?
I'm more hopeful now.
You're hopeful?
I'm more hopeful now than I was when I started. And we churned out the numbers of people blind, but we never churned out the numbers of people who benefit.
Yeah, and your thing is very much the benefit to the economy and to society.
I think
data.
We need to change our narrative from numbers of people blind and visually impaired to numbers who need services and numbers who could benefit if we intervened early. So we change it to a positive narrative, and we push it from both ends. We push it from the top, from the global level. I mean, having eye health in Wish Summit is a major, major change. So if we had eye health featuring in all global non-health meetings, then that would be a plus. And we push it from the community and the family and the mothers and the children and schools end to the policymakers. They're all politicians. So they want what the people want to do. So if we push from both ends and make eye health a home issue, I think that would be a change.
But what your impetus is to say that the return that a government can get is massive from investing in eye care and not leaving it, for example, to the NGOs, actually taking a lead on it.
Yes, we have the data for that. We have the data that shows the high economic rate of return.
Could you put your mic just up a wee bit closer? Thanks.
We have the data, we've pushed it, but I don't think we've pushed it enough.
Really?
The economic rate of return on investing in eye health, not just for the blind and the visually impaired, but for the productive age group and for the investment in children. How much do we save by investing in child eye health for the future of a country? I don't think we as a community have handed it over to those who know how to push messages to do that. Eye health should be integrated. I always think that eye health should be like the bird that lays a nest in every, and lays an egg in everybody's nests.
Yeah.
And that hen sits on it and hatches it
Yeah.
to the benefit of everybody. So integration, I think, is huge. What's gladdening my heart now is innovation and how eye health can even lead on the technology, not just for eye health, but looking into the eyes and the way it leads to any change in health in the neurosystem. I mean, we've got huge potentials, but we must bring others on board and hand over to them to do the advocacy on our behalf.
Well, could you pass the microphone to Angelia? Because I'm just thinking, you, of course, because you have a kind of global view through the Carter Trust, and I wonder what areas of the world do you think kind of hold the greatest burden in terms of eye care, and how is there a quick fix?
Yeah, if there's a quick fix, please see me after the panel. We would like to use that in some of our proposals. I think with looking at eye care, you can kind of narrow it down. So as was presented earlier, you definitely have the cataracts and the glaucoma and certain disease that affects all populations, regardless of where you are. But you also have the infectious diseases and connected to neglected tropical diseases, or NTDs. And these are diseases that are affecting the most vulnerable of the vulnerable. And of course, once you start adding on blindness into areas that are with high poverty, you just keep that cycle going. It becomes more and more difficult to get out of poverty if you're suffering or at risk of blindness. And with looking at trachoma, the disease that I work on, for those who aren't as familiar with it, it's a bacterial infection with that once you get repeatedly infected, it causes your eyelid to turn inwards so that when you blink, you eventually go blind, and you can't recover from that. And so it's very important not to just state the numbers of people who have gone blind, but like was previously said, those who are at immediate risk, that we can prevent them from going blind. There are at least 40 countries that are endemic for trachoma, and 70% when you look at that burden is in Ethiopia. And you have one country that makes up 70% of the burden, and that's mostly, it's a very populated country. And then neighboring to them, you have South Sudan, that even though they're a small population, we've gone in doing baseline surveys with the Carter Center and the Ministry of Health and found districts that were as high as 80%. We had children that had the advanced stages of the disease at the age of 5. And this is a disease that is supposed to normally impact people when they're in their 50s and 60s, but it's just that bad that you have very young people who are becoming blind. And how does that impact on society? And when you look at what can we do to help, I think it's framing within the SDGs. I think when we start to advocate with governments, it's not just about eye care, but how can we help them achieve their development goals, and how can we integrate into the healthcare system? How can we increase water and sanitation, which is a very big component of preventing some of these diseases. It's things that we don't always think about when we think about eye care, is that water and sanitation is a very big component of that. And then also recognizing, like what was said before, with how do we engage the professionals at the national level. So it's not bringing in outside people in order to provide these programs, but developing professionals who can provide, in the case of trachoma, TT surgeries, and doing that at a very localized level so that they stay within their communities, they continue to help them.
Yeah.
And then diversifying.
Yes, so I was going to say, because what you have is the Lions program, but you also have the Orbis, brilliant Orbis airplane, but actually coming in and going away is one thing, and it's very valuable. But what you want to do is train people within, so it's a kind of embedded.
Right.
And I wonder what you think about the resistance by government to actually taking on the scale of the problem. I mean, presumably the impact in the next 10 years in terms of the economic impact of the increase in trachoma is going to be massive.
Well, and I think it very much depends on the government. For example, in South Sudan, which is a country that I lived in for 4 years, the government very much wants it to be a national-based program. And part of that, unfortunately, is because of the war. And what they found is that as soon as the current war started, the NGOs left and the eye care system kind of imploded on itself. And when you're looking at vulnerable populations, you can't get more vulnerable than ones that are trying to flee from conflict. And they've really asked, please train people at the local level. Yeah. Help us have trainers of trainers. That's also another issue. Is a lot of time we come in and we do the training for a certain level, but we haven't created trainers of trainers within the country so that it can be a sustainable process.
So, Govind, picking up on that, the training of trainers, actually, that's the exponential impact of that, if a government would just simply take that on, would be phenomenal.
It would be, but we have to be very realistic. That's where a lot of assistance is needed because, for example, we set up, in my previous job, we set up a school of optometry in Malawi, Mozambique, Eritrea, etc., and a couple other, Vietnam, Haiti. But that was only possible because we managed to get funds out of selling intellectual property and use that money to fund it. Right. Because no donor wants to touch that. Every donor that does the allocation says, the guy doing the allocation says, I'm here 3 years, the benefit of this will be after I'm gone. It's not part of my KPIs. Some other guy's going to look great. You know,
so
even at a government
they
level.
only want the quick hit.
Exactly, because and their budgets and who gives them money places restrictions. So I think we have to look at more cost-effective approaches, but we have to look at getting national ministries on board, education ministries on board, to start investing in education and being able to take this on board, basically.
Which brings into the equation, Peng, that what you were saying in the report and what you were saying to me last night is that health services in whatever country have to be prepared to partner more seriously with industry, because industry's got the money.
Well, I mean, I think the partnership, and particularly on the field of innovation, which is the field, I don't know, any more contemporary innovation that hasn't gone through some part of industry. Because if we work in the public sector, you have a different skill mix to people who are very skilled in regulatory and all the other things that we do. And so actually, part of this skill in modern life is how to work with industry. So take our work on artificial intelligence. Right? We together with DeepMind, which is now part of Google, this is probably the world's most sophisticated algorithm for diagnosing eye disease. Without working with them, it's almost impossible to see. We tried to do this in the public sector, but it's just not possible. And there's a certain amount of what I call legwork. So for instance, you heard this, those of you who came to the AI session this morning, the curation of the data, which is making sure it's clean, it's good. You can't just throw data at AI. You've got to make it into an absolutely, well, it took about 18 months to 2 years, including the teaching algorithm. The AI itself went from a newborn baby probably to the world's best diagnostician in half an hour. So you can understand the amount of groundwork that needs, and actually this is true of virtually every single development we see. You see the invisible 99% perspiration, and then there's the 1% inspiration, which we all think is fantastic. So everything we do actually has that sort of ratio. So we have to find partnerships within the work. So if you've got a fantastic new device and treatment which can do glaucoma surgery in 10 minutes, our 10-10-10 target. So get the pressure to a pressure of 10, which most people stops the disease absolutely at that point. Make it last for 10 years, but do it in 10 minutes. That do it in 10 minutes, which makes it practical on a worldwide scale, takes a lot of industrial development. So, and the same with other techniques that might be useful for other diseases. So you have to have, and the British government at the moment has other ways of looking at this, because if you cannot create these effective partnerships, you won't be able to do some of these things.
Let's get the lights up and get contributions on the floor, please. The microphones are where? Yeah. Okay, can I have the woman at the back there with a hand up with one microphone here, and can I get another microphone right in the middle? Can we get a microphone to the woman in the burgundy top in the middle too? Okay, can I have your question there? Can you put up there? What's the number of that one, please? The microphone?
4.
4. Can microphone 4, please.
Hello, everyone. I'm Martina, and I'm health economist at Imperial College. Thank you very much for a wonderful talk. I still think that people don't realize how eye is important. And as a health economist, I'm always thinking about innovative payment mechanisms, or who will foot the bill, because now we live in a period when there are almost a gene therapy for curing the blindness, but this probably won't be available for the majority. So in your thoughts, for those who are the poorest in the society, for low and middle income countries, is it the most effective to pay these services from private, from donor funding, or is it a public sector that can pay the most effective interventions there?
Adai, what do you think? Most effective from public funding or from donors to do the surgery, which is the best? Or I suppose it must differ country to country. There can't be a single bullet for this.
Yes, of course, but these countries often have very broken public system. They can't afford to pay the universal health coverage. So what are the risk-sharing schemes that can be implemented to fund these screening programs, to fund the train of the personnel there?
Adai.
I think like she means like funding to increase the awareness for the patients and to outreach for more populations for the proper treatment. Like here we do in Doha, as I told you, like we do like campaign. So we invite a lot of populations where they get this proper screening and management. And Hamad Medical Corporation, honestly, they offer this all for free. Like most of our patients here, they just pay for just a few.
Because I mean, I suppose the difference is Hatta it makes it a priority and has the money. And I wonder, Kovan, when it's not, the money isn't available.
Yeah. So I think that one of the problems is that we have all these camps. It's either the government must do it, or private sector must do it, or we need social entrepreneurship. But I think what we really need in a lot of countries is a systems approach to this. We need to look at different levels. For example, I think the poorest of the poor in most countries, government needs to take responsibility for them. There's what we call the working poor. In many countries can afford to pay towards some service. And I think there's an opportunity to bring in cost recovery systems within that sector, which ultimately then reduces the people that government is responsible for. And I think you need a viable private sector. So in many ways, we need a combination of, we need a full ecosystem to operate within these countries to be viable. Because until some of these countries, the poorer countries, reach a level of having the resources of an NHI, like the UK, you know, just only advocating for that is going to mean that we're knocking on a door that's going to open maybe too late. Of course, that would be the best if government can provide for everyone.
Let's take the young woman bang in the middle, and then there's a gentleman here, and then I want the microphone to go right up there. So fire away, please. And yes, and there too.
Hello to everyone in the room. I would like to acknowledge the panelists. For my question, as we all know, technology advances and it's continuous. We focused on having children, intervening with children in their gadget times. I'm sorry, I didn't introduce myself. I'm Gail, a second-year nursing student from the University of Calgary. And my question is, how about the healthcare providers that are exposed to many hours of screen time in a day because we have progressed from paperworks into computer technology-based reports? So what do you have to say about that?
Hannah, would you like to pick up?
I think first of all, those providers would know what the impact on their eye health would be. Make the suggestions to themselves what the change should be, implement those changes, and then transfer to the decision makers to make it policy that it should change. Get the evidence, make the change, and then advocate for policy change.
That's you should do that yourself as a second-year nurse student, remember. Let's take the question here, and then I want that mic to go flying up the back, and one over here. Thank you.
Hello, my name is Hutan Ashrafian. I'm a bariatric surgeon from Imperial College in London. My question is about resource innovation. To what extent do you feel, as a panel, that screening for eye care can be automated? And as a result, that automation to allow non-professionals, you talked about optometrists versus opticians and ophthalmic surgeons, but non-professionals to be able to use technology to screen, for example, school teachers in rural areas, to be able to use computers, to be able to send information. This type of technology is around for screening, let's say, for HIV, malaria, where school teachers are taking pinprick blood tests and sending off. And maybe something could be used in a similar way in eye care.
Liz.
Yeah, I think it's a possibility to use new technologies to both screen children in schools, as well as for other workforces like community health workers to do very basic vision screenings and dispense reading glasses and refer those on to advanced care. But I'd also just like to note that we can already do that without new technology, and that teachers can be trained as it is to screen those children, and same with community health workers. And so that's been going on across the world. It's very much a proven solution that you can train teachers to screen children, and you can train community health workers to screen adults for basic vision problems. And then they put in a referral mechanism for more advanced care. So certainly the new technologies can expedite what we've already known to be true. So it's a really exciting possibility. And I'll just add, as we screen individuals outside of the healthcare system, we're identifying those, whether the children or adults, who have more serious problems, and we're bringing them into the healthcare system. So whether it's in a school or in a remote community, this is a great way to bring individuals who are not currently accessing the healthcare system into the system.
Liz, just when you were saying that without technology, teachers can do it. I mean, I remember at school you had the big thing up on the wall, but that, is, to your point, takes, what, 10 minutes a child? 5 minutes a child, whereas presumably with technology, it's 30 seconds a child.
Yeah, so it's coming down to about 3 minutes or less, yeah.
And, sorry.
Yeah,
and
yes.
I want to add, and I think when we think about innovation too, we also have to think about innovating ideas not connected to technology. So living in a country in an area with no electricity, that I only got to charge my computer sort of once a week, thinking about how can we set up a system that can access people. And for example, in South Sudan, they realized that by keeping people overnight in a sort of pop-up tent and offering food significantly increased the number of people who were coming in to get the surgery. And that's because often women would say, I can't get this sight-saving surgery because I have to feed my children. So then by having this tent, basically we're like, bring your children, we'll feed them, I don't want you to go blind. And so when we think of innovation, I don't always want to go to technology because we have to think about other things as well.
Yes, gentleman over here, please. You wanted to ask a question, and then the microphone's in the middle.
Yes, good afternoon or good evening to all of you. I'm from Guinea-Bissau. It's a country where we have a lot of eye problems, and I think Dr. Anna Fall can really confirm that, because we started with what we call Health for Peace initiative. It was in the Gambia, and she was one of the consultants, to help us set this program. And Sightsavers is really helping us in implementing this program. What I want to say here is that in Guinea-Bissau, we had a lot of problems related to personnel, the staff. In all the country, we have only 3 ophthalmologist doctors. 3. Although it's a very small country, but I think it's very insufficient for a population of nearly 2 million. Only 3 national ophthalmologists. So my question is, my worry is that, okay, just to tell you that I'm coordinating the partnership unit of the Ministry of Health. How can we really, because even the people, they don't want to get trained in ophthalmology. We have a medical school, people are going outside to abroad for studies, but never epidemiology.
Well,
ophthalmology. Ophthalmology.
So wait a minute. So that's interesting, because you say that people will go outside the country to learn how to put makeup on and everything. Do you think that much as they did with, I think it was physics and chemistry teachers where we had a shortage in the UK, they paid them a premium. Do you think if you said, we're going to pay ophthalmology students a premium, you might get more, or is that not possible?
No, I can't answer that question really, because for many times and often we've been trying to convince, sensitize those people, but, you know, they just say no.
They just say no, Hannah.
Why? I don't know.
Why? Can I have the mic up? Thanks.
I think in countries like Guinea-Bissau and in Gambia, I can say when I went to the Gambia, I was the only ophthalmologist for 800,000 people. So I quickly made up my mind that I couldn't sit in a clinic all day, even if I did for my entire career, I couldn't deal with the problem. So I turned the thinking upside down. I wasn't responsible for the individuals who walked in, but I was responsible for the entire population. So I put into place a plan for getting eye care to the entire population, making use of what was available. And what was available were homes and families and traditional practitioners and traditional birth attendants and school teachers. Whoever had any contact with the people, I gave competencies to do what was required. And every nurse knew about eye health. So I turned ophthalmology into public health ophthalmology, and then trained the nurses to do eye health so that nobody needed to travel more than 30 kilometers to even have cataract surgery done. And
so you're training nurses to do the ophthalmology?
Well, I didn't call it ophthalmology.
You just
I
call
think
it
you
health.
have to watch the terms
professional,
used.
yeah.
So I trained them to be eye health providers and to be responsible for the eyes of the population rather than for the disease. So it's got to do with the philosophy, it's got to do with making the most of what you have, including traditional people.
Yes.
So I know when colleagues said that
it's on,
that there were only 3 ophthalmologists, people would have been surprised, but that's the reality for a lot of countries in Africa, that for a long time they've had 2 or 5 ophthalmologists, etc. And in parts of Africa, cataract surgeons are trained, and they have never been to medical school. A lot of them have been either nurses that have been upgraded or people that have been specifically trained to do cataract surgery. So these solutions have been in place, but I think that part of the challenge is that we have done them where an individual NGO or a program wants to do it. I think we need to develop a systems approach to this and develop the appropriate cadres, referral pathways, ensure that people have access. And if we do that, then it'll be sustained.
But
if we don't do that, it doesn't get sustained.
But Adaya, you were saying that when you were at university, it wasn't a priority to teach you about eye health.
Yeah, like usually in medicine, it's full of total of 5 years at medicine. You spend barely 1 month learning about eye health. And and after you finish medicine, then where the time where you go to internship, we're here. If you were thinking of ophthalmology, then you will have a chance more to go and train yourself in ophthalmology. But during our program, you barely take a month only for ophthalmology.
So you just had to break out and say that after that month, you knew that's what you wanted to do?
No, maybe during our internship, like you get exposed to a lot of things, and then you feel yourself interested in eye care.
That's really that idea that eye care is not an exposed part of the medical degree.
I think all medical schools I've been to, actually all the ophthalmologists basically complain they don't have enough time with the medical students. And you really have to, I go back to the advocacy issue, eye health is such an important component of human life that actually it just has to have a higher profile. And it needs to be brought onto the stage and kept there in its many forms, including working its way into, when you're talking to government, decision makers, everything. Eye health's got to be on the table all the time, because the old adage is if you're not at the table, you're on the menu. more true than ever nowadays with the huge strains on government with the various things they're doing. So that's part of the whole issue. We have to have more airtime.
But I wonder, as a consultant now, do you encourage medical students now to come towards ophthalmology?
Yeah, we do encourage them, but what I face a problem as I'm part of medical education, like as a government, they need to upgrade their policies, like to accommodate more newly graduate doctors where they got trained in ophthalmology. Because here, like for example, here in Doha, like per year we take only 2 residents. And I see it's very few, you know, like if you raise the number and then you encourage a lot of students graduate, like they love to go to enter the traineeship of
but they only take 2 residents a year.
Yeah, so all of them, they will prefer to go to the other departments rather than to apply the ophthalmology because they have only 2 spots, so it's going to be easy messed if they didn't take the chance to be in part of ophthalmology. And I believe ophthalmology all over the world is very highly competitive. So I believe if they raise the issue...
Yes, that's really good. That's really good. Do you know what? I think possibly by the WISH conference in 2 years' time, there's more than 2 residents taken on a year in Doha.
And I think when we also talk about building up sort of that eye care, ophthalmology, and your higher, you have 2 stages. So you're building up those professionals within the country, but you also don't want them concentrated in the cities or the capital, which is a very big problem. So it has to be simultaneous. How do you also train up people that will not just set up clinics in the capital, but will also be based at the state or district level?
Yes, I just want to take this gentleman who's been waiting very patiently up the back, waving, not drowning. Here we go. Yes.
Hi, thanks. My name is Ivor Williams, and actually I'm a healthcare designer.
You're sorry?
Healthcare designer.
Yeah.
So I'm going to take advantage of the amazing panel to ask a bit of a practical question. Because it occurred to me, given the fact that we're going to be sticking around with screens for a while in developed countries, and I'm sure it'll be for developing countries as well, and if we think about the trajectory of technology, like the screens will be replaced by smaller screens, and augmented reality, virtual reality will kind of play its part to kind of become more and more larger parts of our lives. I'm kind of interested if you guys have actually got any practical insights or things that you can maybe translate as things that can help us as designers, as engineers, as makers to kind of think how to avoid making the situation worse for millions of people who are going to be using those screens. Is there something that we can start to understand? Because we just don't know. Like, even listening to the panel today, I'm like, oh yeah, of course, we're adding to the problem. We're not making it easier. Eye health is obviously kind of, you know, under-regarded or underfunded and all these problems, but is there something that comes to mind that we can do to make it a little bit easier?
Peg.
I mean, the story, presumably you're talking about myopia that we've been talking about here, short-sightedness.
Sure.
I mean, the story about myopia in terms of the causation of the phenomenon that sees this big increase in children becoming short-sighted, the sort of culprit has sort of moved to this issue of daylight hours outside. But of course, it makes sense that if you look at some of the experimental work that's been done on myopia, that having activity that's close up is certainly a lot of the models that you have. If you leave animals in close surroundings, they will develop myopia. If you made them live in a box, they'll develop myopia because their world's around them. They spend their time looking. The eye is sort of like a image-seeking organ. I think this is an incredibly important subject, actually, because some of the trials for treatments for myopia still haven't really, like simple eye drops and things, haven't really nailed the story. If we could really home down on, there are lots of other theories about how the light goes to the side of the retina and various other things, why that's the case. If you have a more, if you think looking into infinity, which is of course what we were primarily designed for, you know, we were brought to look into we were designed to look mainly in the distance because that's where our lives were, not here. We weren't evolved to live life here. Then some form of design where we're looking more into infinity, going back to your design question, potential, and that'd be one a really interesting experiment to do. And that begs for more research into this area, because if you could, because you see, in theory, virtual reality is an infinity viewing device. When you're putting.
But you're looking at it here, though.
No, but it depends on how your eyes focus. You see, if you do it so that you think your eyes work as if they're looking into infinity,
tricking your eyes,
which
into
is what
looking at
virtual
infinity
does, then in theory, if the experiment was right, you could develop that. So it'd be an interesting thought.
Just briefly, because I've got.
So I'm glad you raised this question, but I think we need to clarify one thing, and you've touched on it. Is actually the research is showing that you can spend time on screens, but you must juxtapose that with at least more than 2 hours a day on average outdoors.
Yeah.
So increasingly the shift is the time outdoors has to be balanced. But where you need to have the interventions to stop your kids from being, so they don't become so addicted that they don't go outdoors. So that's really the predominant thinking that's emerging from the research around time outdoors and screen. So we've got to be very careful about how we react to this issue. It's a bigger issue in the Middle East because the kids may not be able to go outdoors. Yeah. So I think where the intervention, the design is needed is virtual reality that provides distance viewing but also can simulate daylight, and that's the big challenge. If we simulate daylight, it's just too much. You can't do that. Nobody's done that at that level of intensity indoors. And that's really the challenge for us now in this space.
Gentleman right in the middle.
Thank you. Yes, and thanks to the panel. It's a great discussion. My name is Rob Walters. I'm from Orbis. I'm an ophthalmologist. And we were having a little talk earlier on, which I wanted to raise the issue now, which is about trachoma, really. And that is that we were discussing earlier, are we beginning to fool ourselves into thinking we are going to eliminate trachoma? And is it realistic? Because I'm not convinced.
Not convinced. No. Angelia.
Well, she definitely has more of the experience. But
I think you should talk about it.
I think, we set these goals, and sometimes we set the goals based off of the research that we have at the time. And it's always important to continue to do research in order to improve the interventions. And with trachoma, at least, what I'm starting to see is we are making significant progress in a lot of countries, in Amhara and Ethiopia and these other places. But there are a growing number of sort of special populations that are not the low-hanging fruit. So we've worked very hard to get the ones that are easier to access, but there are groups like your nomadic population, your pastoralists, and then right now, because we have such a high number of displaced people that are moving across different parts of Africa, displaced populations that are really changing the dynamic within countries. And countries that have gone very far in almost reaching their elimination target now have, in the case of Uganda, 2 million South Sudanese refugees. And so how do we start to shift our thinking from providing a country level or district level intervention program to a population-based program, recognizing that populations transcend borders?
You wanted to add to that, Hannah?
Yes, before we started the panel, we looked at, in the Gambia, the different scenarios. One village preceded all the trachoma control activities and eliminated blinding trachoma. I would say elimination of blinding trachoma rather than elimination of trachoma is probably a more realistic goal. The second scenario was the ribbon of underserved population around an urban area where social amenities were not available, poor water supply, and poor sanitation. I don't think the trachoma control program is emphasizing and funding those two components of the SAFE as much as they are funding the S and the A. Right. So, and those two areas are not necessarily health issues. We're not bringing in the sanitation engineers or the water providers as much. I mean, putting the onus on them to say that you are eliminating a blinding disease as much as you're providing water for a population. So, as I said, passing the buck
to public health.
To public health.
Absolutely. Now, if there's no more questions in the hall, I've got a final question for the panel. starting from you, Peng, going right, if there was one thing that you could do that would improve healthcare right now over the next 2 years to the next WISH conference, what would it be? Now that eye health is on the agenda, how would you capitalize on that? What would be something that you could do over the next 2 years to improve eye health? I'll go around the panel, just quick answer from each.
Well, I mean, I'm slightly thinking in my particular field, where actually we can get close to what we call the 10-10-10. This is my particular speciality. I think we could change the treatment of glaucoma across the entire world, a disease that otherwise is relatively intractable. So from that point, definitely within 2 years, you could make that sort of progress of developing that treatment.
Cool.
Investment in developing the appropriate human resources for countries' needs.
Yeah. Liz?
Training of community-level health workers to do basic vision screenings and become a point of triage for all eye health.
For me, to increase the awareness among our population about the importance of early screening and detection and treatment of different kinds of diseases. Because I see in our population, like, unless they notice that decrease of vision, then they will come to eye clinic. They won't come earlier than this. So I see this is a big issue among our population.
I would turn the health pyramid upside down, put the homes, families, communities, and the health providers at the top, and make sure that eye health is a good component of primary health care, and eye health is integrated into all health systems and non-health systems that impact on health.
Angelia?
And for me, even though it would take longer than 2 years, really doing more with water and sanitation and recognizing that at the heart of it, it builds up communities, it makes communities healthier, and that will have a large impact.
Ladies and gentlemen, please thank our panel very much.